Your kidneys are filtering your blood right now, removing waste products, balancing electrolytes, regulating blood pressure, and maintaining the precise chemical environment that every cell in your body depends on to function. They perform these tasks silently and continuously, processing approximately 180 liters of blood every single day and concentrating waste into roughly 1 to 2 liters of urine. When kidneys are healthy, you are completely unaware of this filtration process. When they begin to fail, the early stages are often equally silent, which creates a dangerous paradox. Kidney disease can progress from normal function to end-stage renal failure requiring dialysis or transplantation over years or even decades, and many people remain asymptomatic until kidney function has declined to less than 25% of normal capacity. By that point, the damage is typically irreversible, and treatment becomes focused on slowing progression rather than restoring function. The tragedy is that kidney disease is both highly prevalent, affecting approximately 1 in 7 adults in developed countries, and largely preventable when risk factors are identified and managed early. The question that determines outcomes is not whether kidney disease can be treated once advanced, because options at that stage are limited, but whether the early warning signs can be recognized when intervention can still preserve kidney function. What makes kidney disease particularly insidious is that the kidneys have enormous reserve capacity. You can lose 50% of your kidney function and still have no symptoms whatsoever, because the remaining functional nephrons, which are the filtering units of the kidney, compensate by increasing their workload. Standard blood tests may show only subtle abnormalities that are often dismissed as normal variation. It is only when kidney function drops below 30 to 40% of normal that waste products begin to accumulate in the blood at levels that produce noticeable symptoms, and by that point, significant structural damage has already occurred in the form of scarring, reduced nephron numbers, and irreversible loss of filtration capacity. The 6 signs that indicate kidney failure is developing are not the dramatic presentations that bring patients to emergency departments, such as complete cessation of urine output or severe fluid overload requiring urgent dialysis. Those are late-stage manifestations. The 6 signs I am discussing are the subtle, easily dismissed symptoms that appear when kidney function has declined to the point where intervention is still possible, but the window is closing. Hi, I am Dr. Alex. I am an emergency medicine doctor, and after nearly 10 years working in accident and emergency, I have seen what happens when kidney disease progresses unrecognized until it becomes a medical crisis. I have managed patients in acute kidney failure who required emergency dialysis because their kidneys could no longer clear the toxins that were poisoning every organ system. I have treated patients with severe fluid overload and pulmonary edema because their kidneys had lost the ability to regulate fluid balance. I have seen young people in their 40s and 50s facing lifelong dialysis or transplantation because chronic kidney disease that could have been managed was allowed to progress silently for years. My goal now is to help people recognize the warning signs of kidney dysfunction early, when kidney function can still be preserved through lifestyle modification, medication, and management of underlying conditions like diabetes and hypertension. For the next several minutes, I am going to explain what each of these 6 signs represents biologically, why they occur when kidneys begin to fail, and what should be done if you recognize them in yourself or someone you care about. Before discussing the specific signs, we need to understand what kidney failure actually means and what causes it, because the symptoms only make sense in the context of the underlying pathology. Kidney failure, more properly termed chronic kidney disease, is defined as a progressive loss of nephron function, resulting in reduced glomerular filtration rate, which is the volume of blood the kidneys can filter per minute. Normal glomerular filtration rate is approximately 90 to 120 milliliters per minute per 1.73 square meters of body surface area. Chronic kidney disease is staged based on glomerular filtration rate, with stage 1 representing kidney damage with normal or elevated filtration rate, stage 2 representing mild reduction to 60 to 89 milliliters per minute, stage 3 representing moderate reduction to 30 to 59 milliliters per minute, stage 4 representing severe reduction to 15 to 29 milliliters per minute, and stage 5 representing kidney failure with filtration rate below 15 milliliters per minute, or the need for dialysis. The symptoms that patients notice typically begin to appear in stage 3 and become prominent in stages 4 and 5. The causes of chronic kidney disease are diverse, but the most common are diabetic nephropathy, which accounts for approximately 40% of cases, and hypertensive nephropathy, which accounts for another 25 to 30%. Diabetic nephropathy develops when chronic hyperglycemia damages the small blood vessels in the glomeruli, which are the filtering units of the nephron. High glucose levels cause glycation of proteins in the basement membrane, increase oxidative stress, and activate inflammatory pathways that lead to thickening of the glomerular membrane, scarring, and eventual loss of filtration capacity. Hypertensive nephropathy occurs when chronic elevated blood pressure damages the afferent and efferent arterioles that regulate blood flow through the glomeruli. Over time, this leads to glomerulosclerosis, which is scarring of the glomeruli, and tubulointerstitial fibrosis, which is scarring of the tubules and supporting tissue. Other causes include glomerulonephritis, which are inflammatory conditions that directly attack the glomeruli, polycystic kidney disease, which is a genetic condition where cysts progressively replace normal kidney tissue, chronic obstruction from kidney stones or prostate enlargement, and nephrotoxic medications, including certain pain relievers, particularly non-steroidal anti-inflammatory drugs when used chronically. The first sign that kidneys are failing is persistent changes in urination patterns, and this can manifest in several ways. The most common is nocturia, which is the need to urinate multiple times during the night. When kidneys are functioning normally, they concentrate urine during sleep, allowing most people to sleep through the night without needing to urinate. When kidney function declines, the ability to concentrate urine is lost early in the disease process. The damaged tubules cannot reabsorb water efficiently, so urine remains dilute and larger volumes are produced throughout the 24-hour period, including during sleep. Nocturia is often dismissed as a normal consequence of aging or attributed to prostate issues in men, but when it represents new onset or worsening frequency, particularly waking 3 or more times per night to urinate, it warrants investigation of kidney function. The second urinary change is foamy or frothy urine that persists and does not dissipate quickly. This occurs when protein is being lost in the urine, a condition called proteinuria. Normally, the glomerular filtration barrier prevents large molecules like proteins from passing into the urine. When this barrier is damaged, as occurs in diabetic nephropathy, glomerulonephritis, and hypertensive kidney disease, proteins leak through and create foam when urine is agitated. Significant proteinuria is a marker of advanced glomerular damage and indicates that kidney disease is already moderately advanced. The third urinary change is visible blood in the urine, termed hematuria, which can range from pink or tea-colored urine to frank blood. While hematuria can have many causes including urinary tract infections, kidney stones, and bladder cancer, when it occurs in the context of other signs of kidney dysfunction, it often indicates glomerular disease or interstitial nephritis. The second sign is persistent fatigue and weakness that is disproportionate to activity level and does not improve with rest. This symptom is multifactorial and reflects several consequences of declining kidney function. The first mechanism involves anemia. Healthy kidneys produce erythropoietin, which is a hormone that stimulates the bone marrow to produce red blood cells. When kidney function declines, erythropoietin production falls, and the bone marrow does not receive adequate stimulation to maintain normal red blood cell production. The result is a normocytic normochromic anemia, meaning the red blood cells are normal in size and hemoglobin content, but reduced in number. Hemoglobin levels often fall to 8 to 10 grams per deciliter in advanced kidney disease, compared to normal levels of 12 to 16 grams per deciliter in women and 13 to 18 grams per deciliter in men. Anemia reduces oxygen delivery to tissues, and the result is profound fatigue, reduced exercise tolerance, and weakness. The second mechanism involves the accumulation of uremic toxins. When kidneys fail to clear waste products adequately, substances like urea, creatinine, and various organic acids accumulate in the blood. These compounds interfere with cellular metabolism, impair mitochondrial function, and create a state of chronic malaise and fatigue that is not relieved by sleep or rest. The combination of anemia and uremic toxicity creates a level of fatigue that is qualitatively different from normal tiredness and progressively worsens as kidney function declines. The third sign is loss of appetite and unexplained weight loss, often accompanied by nausea and a metallic taste in the mouth. This occurs when uremic toxins accumulate to levels that affect the gastrointestinal system, and alter taste perception. Urea is broken down by bacteria in the mouth and gastrointestinal tract into ammonia, which creates a metallic or ammonia-like taste and causes chronic nausea. The accumulation of uremic toxins also causes gastroparesis, which is delayed gastric emptying, leading to early satiety, bloating, and reduced food intake. Patients with advancing kidney disease often describe feeling full after eating only small amounts and losing interest in food entirely. The resulting weight loss is typically gradual but progressive, and when combined with muscle wasting from the catabolic effects of uremia and inadequate protein intake, it creates a state of protein-energy malnutrition that significantly worsens outcomes. This symptom cluster is particularly concerning because it indicates that kidney function has declined to the point where metabolic waste is accumulating at toxic levels. The fourth sign is swelling, medically termed edema, particularly in the lower extremities, ankles and feet, and in more severe cases around the eyes and in the hands. Edema in kidney disease occurs through two primary mechanisms. The first is sodium and water retention. When glomerular filtration rate falls, the kidneys lose the ability to excrete sodium efficiently. Sodium retention leads to water retention through osmotic mechanisms, and the excess fluid accumulates in the interstitial spaces, particularly in dependent areas where gravity causes fluid to pool. The second mechanism is proteinuria, leading to hypoalbuminemia. When large amounts of protein are lost in the urine over months or years, serum albumin levels fall. Albumin is the primary protein responsible for maintaining oncotic pressure, which keeps fluid in the bloodstream rather than allowing it to leak into tissues. When albumin falls below 3 grams per deciliter, oncotic pressure drops and fluid shifts from the vascular space into the interstitial space, causing edema. The combination of sodium retention and low albumin creates pronounced swelling that typically begins in the ankles and feet and can progress to involve the legs, hands, face, and eventually the lungs, causing pulmonary edema and shortness of breath. Edema that is new, progressive, or associated with rapid weight gain, which reflects fluid accumulation rather than fat or muscle gain, should prompt immediate evaluation of kidney function. The fifth sign is difficulty concentrating and cognitive impairment, ranging from subtle memory problems and reduced mental clarity to confusion and difficulty following conversations. This neurological symptom complex is termed uremic encephalopathy and occurs when kidney failure allows neurotoxic waste products to accumulate in the bloodstream and cross the blood-brain barrier. The primary culprits are urea and other small molecular weight compounds that are normally cleared by the kidneys. When these accumulate, they interfere with neurotransmitter function, alter neuronal membrane potentials, and create a toxic metabolic environment in the brain. Patients describe feeling mentally foggy, having difficulty concentrating on tasks that were previously routine, forgetting appointments or recent conversations, and experiencing slowed thinking. In more advanced cases, particularly when kidney failure is acute or when chronic kidney disease reaches stage 5, patients can develop asterixis, which is a flapping tremor of the hands, altered consciousness, and even seizures. The cognitive symptoms of uremic encephalopathy are often subtle initially and may be attributed to aging, stress, or depression, but when they occur in the context of other signs of kidney dysfunction, they indicate that uremic toxins are affecting brain function and that kidney disease is advanced. The sixth sign is persistent itching, medically termed pruritus, that is often severe, generalized, and not explained by skin conditions like eczema or dry skin. Uremic pruritus is one of the most distressing symptoms of advanced kidney disease and significantly impairs quality of life. The mechanism is not entirely understood, but appears to involve several factors. First, the accumulation of uremic toxins in the skin creates direct irritation. Second, secondary hyperparathyroidism, which develops when kidneys fail to activate vitamin D and regulate calcium and phosphate metabolism, leads to elevated parathyroid hormone levels and abnormal calcium phosphate deposition in tissues including skin. Third, dry skin, which occurs due to impaired sweat gland function and altered hydration in kidney disease, exacerbates itching. Fourth, inflammatory mediators and altered immune function in uremia may trigger histamine release and neurogenic itch pathways. The itching is typically worse at night, interferes with sleep, and is often resistant to standard antihistamine treatments. Patients describe it as deep, burning, or crawling sensations that are only temporarily relieved by scratching. When itching is severe, persistent, and occurring without obvious dermatological cause, particularly in the context of other symptoms on this list, it should prompt evaluation for kidney disease. In emergency medicine, we see patients with kidney failure when it has progressed to the point of causing acute crises. We manage acute pulmonary edema from fluid overload requiring urgent diuresis or dialysis. We treat severe hyperkalemia, which is elevated potassium that can cause life-threatening cardiac arrhythmias when kidneys cannot excrete potassium adequately. We manage uremic pericarditis, which is inflammation of the lining around the heart caused by uremic toxins, and uremic encephalopathy, severe enough to cause altered consciousness. What becomes painfully evident is that these patients almost always had warning signs for months or years before the crisis. They had nocturia that they dismissed. They had fatigue that they attributed to stress or aging. They had swelling that they thought was just weight gain. They had itching that they tried to treat with over-the-counter creams. The kidney disease was detectable with simple blood tests measuring creatinine and estimating glomerular filtration rate, but either they never had the test done or the results were not acted upon when they showed early decline. The critical window for preserving kidney function is in stages 2 and 3 of chronic kidney disease, when glomerular filtration rate is between 30 and 89 milliliters per minute. At this stage, interventions including tight control of blood pressure, optimization of blood glucose in diabetic patients, use of medications like angiotensin-converting enzyme inhibitors or angiotensin receptor blockers that protect the kidneys from further damage, reduction of dietary protein to decrease the workload on remaining nephrons, and avoidance of nephrotoxic medications can significantly slow or even halt progression. Studies have shown that aggressive management of diabetes and hypertension can reduce the rate of kidney function decline by 50 to 70%. However, once kidney disease reaches stage 4 with glomerular filtration rate below 30 milliliters per minute, the ability to preserve function is limited and the focus shifts to preparing for dialysis or transplantation. The approach when any of these 6 signs are recognized should be immediate evaluation with basic laboratory tests. This includes serum creatinine to assess filtration function, with glomerular filtration rate calculated using the creatinine level, age, sex, and race. It includes urinalysis to detect protein, blood, or casts in the urine, which indicate glomerular or tubular damage. It includes measurement of electrolytes, including potassium, which can become dangerously elevated in kidney failure, and bicarbonate, which can become low due to metabolic acidosis. It includes measurement of hemoglobin to assess for anemia. If kidney disease is confirmed, additional testing should include measurement of parathyroid hormone and vitamin D levels, assessment of calcium and phosphate to evaluate for mineral bone disease, and often imaging with ultrasound to assess kidney size and structure. In some cases, referral to a nephrologist for consideration of kidney biopsy may be appropriate to determine the specific cause of kidney disease and guide treatment. The interventions that slow progression differ based on the underlying cause, but share common elements. For diabetic nephropathy, achieving tight glycemic control with hemoglobin A1c below 7% significantly reduces the rate of progression. Sodium glucose cotransporter 2 inhibitors, which are a class of diabetes medicine, have been shown in recent trials to provide kidney protection independent of their glucose-lowering effects, and are now recommended for all patients with diabetic kidney disease. For hypertensive nephropathy, achieving blood pressure targets below 130 over 80 millimeters of mercury, and sometimes lower depending on the level of proteinuria, is essential. Angiotensin-converting enzyme inhibitors and angiotensin receptor blockers are first-line agents because they reduce intraglomerular pressure and provide renal protection beyond their blood pressure-lowering effects. For all causes of chronic kidney disease, dietary modifications, including limiting protein intake to 0.8 grams per kilogram of body weight per day to reduce the metabolic burden on the kidneys, restricting sodium to less than 2 grams per day to reduce fluid retention and blood pressure, and managing potassium and phosphate intake as kidney function declines are important. Avoidance of nephrotoxic medications, particularly non-steroidal anti-inflammatory drugs, certain antibiotics, and contrast dye used in imaging studies is critical to preventing further damage. The distinction between chronic kidney disease and acute kidney injury, which is a sudden decline in kidney function over hours to days, is important because the causes, management, and prognosis differ substantially. Acute kidney injury is often reversible when the underlying cause, such as dehydration, infection, obstruction, or medication toxicity, is identified and treated promptly. Chronic kidney disease is typically irreversible and progressive, though the rate of progression can be slowed. The 6 signs I have described are characteristic of chronic kidney disease that has been developing over months to years. Acute kidney injury typically presents with more dramatic symptoms, including sudden cessation of urine output, rapid onset of severe edema, confusion developing over hours rather than weeks, and sometimes visible blood in the urine from acute tubular necrosis or glomerular damage. Your kidneys are failing if you notice persistent changes in urination, including nocturia, foamy urine, or visible blood. They are failing if you experience profound fatigue and weakness disproportionate to your activity level. They are failing if you develop loss of appetite, nausea, and unexplained weight loss. They are failing if you notice progressive swelling in your ankles, feet, or around your eyes. They are failing if you experience difficulty concentrating and cognitive impairment that is new or worsening. They are failing if you develop severe persistent itching without obvious skin cause. These 6 signs represent the clinical manifestations of declining glomerular filtration, accumulation of uremic toxins, anemia from reduced erythropoietin production, sodium and water retention, protein loss in the urine, and metabolic disturbances affecting multiple organ systems. The appearance of these symptoms indicates that kidney function has likely declined to stage 3 or beyond, and that intervention is urgently needed to preserve remaining function and prevent progression to end-stage renal disease requiring dialysis or transplantation. The time to act is not when symptoms become severe, but when they first appear, because the earlier kidney disease is identified and managed, the better the outcomes and the greater the likelihood of preserving kidney function long term. Finally, if you found this information valuable and believe it could help others recognize the warning signs of kidney disease before it progresses to crisis, please subscribe to the channel. Every subscription helps this content reach more people who need to understand the symptoms of kidney failure and the importance of early detection and intervention. I am committed to continuing to provide scientifically grounded medical information that can genuinely improve health outcomes and prevent the devastating consequences of unrecognized chronic disease. Thank you for watching.